Hypertension in 10 minutes. So what is hypertension? Hypertension is defined in people ages 13 and older as a blood pressure greater than 130 over 80. And in pregnancy, it's defined as a blood pressure greater than 140 over 90. Now, in order to diagnose this, you typically have to have at least two different readings, usually at least 4 hours apart. This is typically done in multiple office sessions or at home using home-based monitoring. So why does high blood pressure matter? Well, probably the biggest factor is that high blood pressure is associated with increased risk of mortality from stroke and heart attack. And each 20 millimeter of mercury difference in your systolic blood pressure doubles your mortality rate from stroke and heart attacks. But it also has long-term effects on kidney function, heart function, and more. So what symptoms will people have? None, unfortunately, and that's the hard part. However, if blood pressures are very high, usually greater than 160 over 110, there can be signs and symptoms of hypertensive emergency that suggest poor blood flow to different organs. This blood flow change could cause problems with vision changes, headaches, focal weakness, shortness of breath, chest pain, severe abdominal pain, and swelling in the hands and feet. If you notice any of these signs and someone's blood pressure is significantly elevated, you should send them to the emergency room. So what is our goal blood pressure? Well, for most patients, it's going to be 130 over 80, the same numbers that we use to diagnose high blood pressure. However, there have been plenty of studies to show that a blood pressure of 120 over 70 actually does show some benefit. But the issue is that this puts you at higher risk of hypotension, and we rarely target this. Now, we can also have a more lenient goal of 140 over 90 for older patients who might be at risk of hypotension if they're trying to reduce their polypharmacy, or in the situation that we talked about earlier with pregnancy. So how can we get to our goal? The first thing that we always try is lifestyle modification. So this graph is going to show differences in blood pressure reduction by different types of things we can do to modify a patient's lifestyle. The first thing is diet, more specifically the DASH diet, or dietary approaches to stop hypertension. This has been shown consistently across multiple studies to reduce your blood pressure. Part of this diet has to do with eating a diverse set of fruits and vegetables, but also lowering your sodium and increasing your potassium, which in isolation have also been shown to lower your blood pressure. Now, in blue, we have dietary factors, and in green, we also have exercise factors. So both aerobic exercise and resistance exercise have been shown to lower your blood pressure. And when you take diet and exercise together, we also see that weight loss is associated with lower blood pressures. Now, there are a couple other behavioral modifiers that also affect people's blood pressure, but have larger impacts on people's overall health that we should not ignore. Quitting smoking, reducing alcohol, and getting quality sleep all can improve people's health with regards to high blood pressure and also other things. And when you look at the AHA recommendations for what leads to a healthy lifestyle, dietary changes, exercise, quitting smoking, reducing alcohol, and quality sleep are all referenced. And for these reasons, I talk about this with every single one of my patients. So when lifestyle modifications are not enough, we need to consider medications to help us get to our high blood pressure goal. So there are 4 first-line medication classes that we should consider when trying to treat someone for high blood pressure. So the different 4 classes are ACE inhibitors, angiotensin receptor blockers, calcium channel blockers, and thiazide-like diuretics. So within the ACE inhibitors, examples would be enalapril, lisinopril, and captopril, among others, and you can always identify them by the suffix pril. Side effects of ACE inhibitors are a dry cough, and in some patients they can develop angioedema, which is swelling of the lips that can cause airway compromise. They also, by affecting renal blood flow, can cause an AKI and hyperkalemia, so you should always check a BMP when you start them. Other considerations is that they're particularly helpful in diabetes, kidney disease, and heart failure, and you can't mix them with angiotensin receptor blockers. Moving on to those angiotensin receptor blockers, we can think of examples like valsartan, losartan, and olmesartan, which are all identifiable by the suffix sartan. Similar to the ACE inhibitors, because they affect blood flow to the kidneys, ARBs can cause problems with kidney function and hyperkalemia, so you should always check a BMP when starting them. Just like ACE inhibitors, these are especially good in diabetes, kidney disease, and heart failure, but you should not mix them with ACE inhibitors. Moving on to calcium channel blockers, examples would be amlodipine and nifedipine, and you can identify them by the suffix dipine. Side effects of this tend to be peripheral edema and headaches. And in terms of considerations for them, of these 4 first-line classes, these are the ones that are safest in pregnancy, and so are often good options for people who are potentially interested in becoming pregnant. Finally, the thiazide-like diuretics, like hydrochlorothiazide and chlorthalidone, are good options for controlling people's blood pressure. Side effects would include urinary frequency because they are diuretics, hypokalemia, hyperglycemia, and gout flares. This is also something you can consider if someone has low calcium or has osteoporosis because it can increase people's calcium reabsorption. Now, what happens if we don't reach our goal with one of these 4 first-line medications? So there are 2 main options. One is to consider using multiple classes of medications, often in combined pills, where you combine 2 different classes of medication into one, so that from the patient perspective, they're getting one pill, but they're really getting the power of 2 medications. This is especially important when someone's blood pressure is more than 20/10 above their goal, because it's unlikely for them to develop hypotension with 2 pills in that setting. The other option is to increase someone's dose. And often I talk about with patients these 2 choices and help come to a decision using patient-centered decision making. Now, you should also consider other causes, especially if you need 3 medications at the maximum dose to control someone's blood pressure. In this setting, we would call this resistant hypertension. And at that time, in addition to pursuing different diagnostic workup, we also might consider some non-first-line medications. So what are some other secondary causes of hypertension? Well, the first one that we often see is sleep apnea or obstructive sleep apnea. This is when people are not getting enough oxygen while they sleep, which causes increased blood pressures throughout their pulmonary vascular system and can lead to systemic hypertension. So the first thing I usually do is screen them with a validated questionnaire like the Stop Bank score. And if they show that they are moderate to high risk, I will refer them to get a sleep study called polysomnography, where they'll be observed for not breathing during sleep. If they have a certain number of episodes where they are not breathing while they're sleeping, they may benefit from positive airway pressure. One option like that is continuous positive airway pressure, or CPAP. Another common secondary cause of hypertension is hyperaldosteronism, where our body is secreting too much aldosterone independent of the RAS system. To diagnose this, you can look at plasma renin-aldosterone assays, or look at your BMP, which would show demonstration of the electrolyte abnormalities of hyperaldosteronism. More specifically, that the potassium would be quite low. Once you've done your renin-aldosterone testing and you've identified that someone has hyperaldosteronism, you would then send them to get a CT scan to identify if there is a unilateral adenoma that may be causing this hyperaldosteronism. Another category of diseases that can cause high blood pressure is renal artery stenosis or renovascular dysplasia. This has to do with abnormal function of the blood vessels supplying the kidney. And the way to diagnose that would be to get a renal artery Doppler ultrasound, which will help show restrictions in blood flow to the kidneys. And finally, we should always consider medication-induced causes of hypertension. So combined oral contraceptives that have both estrogen and progesterone, NSAIDs like ibuprofen, steroids, or some nasal congestions can all cause high blood pressure. You should always do a thorough medication review to make sure that these are not the cause of the hypertension that you see in the patient in front of you. Now, once we've ruled out secondary causes and we move past the first line of medications, we also want to consider the less commonly used antihypertension options. So beta blockers are an option, such as metoprolol, labetalol, carvedilol, and atenolol, all of which end in the suffix -lol. Mineralocorticoid receptor antagonists like spironolactone and eplerenone, loop diuretics like furosemide and torsemide, vasodilators like the isosorbide nitrates classes and hydralazine, and then alpha-acting agents, either alpha-1 blockers like doxazosin, prazosin, and carvedilol, which is also a beta blocker, or alpha-2 agonists like clonidine. So here are takeaways from this presentation. Hypertension is defined as high blood pressure over 130/80, which is our usual goal for treatment. Lower blood pressure reduces the risk of stroke and heart attack. Lifestyle management with diet, exercise, smoking cessation, alcohol cessation, and sleep can improve outcomes. ACE inhibitors, ARBs, calcium channel blockers, and thiazide-like diuretics are first line for treating hypertension. You should also consider obstructive sleep apnea, hyperaldosteronism, renal vascular disorders, and medication-induced causes, particularly if someone is younger or has resistant hypertension.